Hello everyone, this is Dr. Madhusudan Rao and the program I teach medical students. This class is meant for purely the clinical students of MBBS. The undergraduate students just entered into the clinical arena. We talk about the auscultation of heart, the part 1. That is, we are going to deal with the heart sounds. I'm Dr. Madhusudan Rao, retired professor of pediatrics and other department of pediatrics. Okay, you know pretty well about it. Look at this picture. The doctor is auscultating the heart of the child. While examining the child patient with regard to the cardiovascular system, you have got to proceed with the auscultation of the heart initially. Before you disturb the patient with percussion, etc., it is better to go ahead with the auscultation of the heart in order to retrieve the findings effectively. And here also, doctor is auscultating the heart of the infant. Well, this is the picture of the heart, salute or heart, which takes untiring effort to beat continuously without taking any rest. The section of the heart showing the 4 chambers, that is 2 atria and 2 ventricles, right and left atria, right and left ventricles, ventricles opening into the great vessels, that is pulmonary artery and the aorta, taking exit from the right ventricle and the left ventricle respectively. Right atrium opening into the right ventricle through tricuspid wall, left atrium opening into the left ventricle through mitral valve. This is the gross structure of this section of the heart. Well, before we proceed with the auscultation of the heart, it is very important to understand the basics of the phases of cardiac cycle. Cardiac cycle begins with the atrial systole and ends with the ventricular diastole. Okay. The duration of the cardiac cycle is 0.8 seconds when the heart rate is 72 per minute. This point has to be remembered. And 0.3 seconds is the systolic phase, and 0.5 seconds is the diastolic period. So cardiac cycle, as I told you, starts with the atrial systole. So what happens during atrial systole? Atrial contraction occurs and forces the blood into the ventricles across the AV valves. Okay. Atrial systole corresponds to P wave of the electrocardiogram. Okay. Then ventricular systole. Ventricular systole occurs in 2 phases, first phase and the second phase. During the first phase, ventricular chamber contracts and the AV valves closes. Okay, with the force, the AV valves are closed. Okay, this is the first phase of the ventricular systole. In this phase, AV valves are closed, semi-neural valves are yet to open. This is described in physiology as the isometric contraction phase. And this phase corresponds to QRS complex of the ECG. Next phase is the ventricular systole, second phase. Here, semi-neural valves open and blood is ejected into the great vessels. Okay. Of course, AV valves remain closed. This phase corresponded to T wave of the electrocardiogram. This is followed by ventricular diastole, which occurs in early and late phases. During ventricular diastole early phase, semi-neural valves closes, so that but blood will not flow in a retrograde fashion into the ventricles. Okay, and atria gets filled up slowly because blood flows into the atria from the right atrium gets filled up with the systemic venous return. Left atrium gets filled up with the pulmonary venous return. Okay, that means here in this phase, there is a seminal are also closed and atria gets filled up and AV walls are to open. This is called isometric relaxation phase. During the ventricular diastole late phase, the ventricular chamber continue relax and blood fills the ventricles possibly from the atria. So most of the blood from the atria, which receives the venous return, right atrium receiving the blood from the systemic venous return, left atrium getting filled by the pulmonary venous return. During the late phase of ventricular diastole, AV valves open, and most of the blood that present in the atria flows passively into the ventricles. Okay, only fraction of the blood remains in the atria, which is emptied into the ventricles during atrial systole. That is active contraction of the ventricles, and remaining blood is ejected into the ventricles. Okay, so with the end of the late phase of ventricular diastole, cardiac cycle ends. Okay, this is all about the various phases of the cardiac cycle, which you have got to remember in order to interpret the various events that happens, say the sounds or murmurs during the cardiac cycle. Then proceed with the auscultation of the heart. The student who is ready to auscultate the heart of the patient, he requires excellent hearing ability. You should not have the defective hearing. Your hearing should not be blocked by the presence of wax or something like that in the ears, and your mind and body should be put together. Should keep total concentration and focus your attention on the auscultation of the heart. You should have the ability to identify subtle differences in pitch and timing of the sounds. Well, you use the diaphragm for high-pitched sounds or the murmurs. Use bell with the little pressure over for low-pitched murmurs. Okay, diaphragm of the stethoscope has to be used for high-pitched murmurs, whereas bell of the stethoscope with little pressure over the chest should use for low-pitched murmurs. And you should examine the patient in supine position, supine and left lateral position, sitting and leaning forward position. Also auscultate in the left axilla to look into the radiation of the murmurs. And auscultate over the suprasternal as well as carotids. And while during the auscultation, you have got to appreciate heart sounds, the murmurs, and rubs. Heart sounds are brief sounds caused by opening and closure of the valves, the systolic as well as diastolic. The murmurs, they are a result of the blood flow turbulence generated across the valve leaflets or into the great vessels or into the chambers. So there is the valvular component, vascular component, as well as muscular component. But most of the time it is a turbulence generated around the valve leaflets that results in the murmurs. So they are longer than sounds. Grading is based on the loudness. You have to appreciate the pitch, location, radiation, and whether they are appreciated with the bell of the stethoscope or diaphragm. And you have to look for the position of the patient where they are best heard and change with regard to respiration in the position. So these points have to be recorded while auscultating for the murmur. We are going to deal these murmurs in detail when you're talking about the murmurs. Rubs are the high-pitched scratchy sounds. Heart sounds. In this class, we are going to touch in detail about the heart sounds. Heart sounds are classified as systolic sounds and diastolic sounds. Here you see the heart sounds, phonographic recording. So first heart sound, lub, second heart sound, lub. First heart sound is of longer duration, higher amplitude, and second sound is shorter duration and low in amplitude. The amplitude of this sound denotes the loudness, and the duration denotes the length of the sound. Well, so first sound corresponds to the closure of the AV valves. You can see here is the point of closure of the AV valves. And the semineural valves closure corresponds to the second heart sound. Let's go in detail. This picture shows the phonographic recording of the heart sounds. You see the amplitude. First heart sound is louder, higher amplitude. Second heart sound is less louder when compared to the first heart sound, and it is louder than the third heart sound. Third heart sound is louder than the fourth heart sound. This is how it is. The graphic representation of the sounds denote about their loudness. So as I told you, heart sounds are divided into systolic sounds and the diastolic sounds. Let's go with the systolic sounds. They are first heart sound and clicks. Systolic phase starts with the beginning of the first heart sound, ends with the second heart sound. Okay, that is the systolic period. The sounds heard during the systolic phase of the cardiac cycle, they are the systolic sounds. They include first heart sound and the clicks. First heart sound is caused by closure of the AV valves, mitral valve predominantly. Mitral valve closure contributes to the first heart sound to the maximum extent. Okay, and tricuspid valve to some extent. Mitral valve closes early, tricuspid valve follows. Split of the first heart sound is difficult to appreciate, but in deep inspiration, you can appreciate the first heart sound split. It is high pitch, loud in mitral stenosis, diminished or absent in mitral regurgitation. Okay, loud in mitral stenosis because valve lips are thick and they are stretched apart for a longer time because there is narrowing of the mitral valve. So it takes a longer time for the ejected blood from the left atrium to flow into the left ventricle. So they are stretched for a longer time. If you apply the Starling's principle, they close suddenly, resulting in the loud first sound. Sudden and strong closure of the valve leaflets results in loud first sound. In mitral regurgitation, there is no appropriate closure of the mitral valves in order to generate the first sound. So the loudness is low. Sometimes it is absent in mitral regurgitation. Then clicks. They are mainly systolic. That's why they are called ejection clicks. There are also non-ejection clicks, which I am going to touch in brief. They are short, high-pitched, follow the first sound. Okay. Sometimes they are late systolic in mitral valve collapse, mid-systolic in myxomas. Okay. The closer the click to first sound, severe is stenosis. Mainly appreciated in aortic as well as pulmonary stenosis, especially valve stenosis. This is because of the abrupt doming motion of the valve coming to an abrupt halt at the onset of ejection. That is the mechanism that results in the click. You try to remember one point. The clicks are appreciated in the aortic as well as the pulmonic stenosis. Okay. These stenosis must be at the level of valves. When you are appreciating a ejectional click, it means you are dealing with aortic or pulmonic valvular stenosis of moderate to mild to moderate severity. It is not you cannot appreciate the clicks when stenosis is at the subvalvular or supravalvular level. Okay, it's only valvular, pulmonic, or aortic stenosis of mild to moderate degree. You can appreciate clicks. So aortic stenosis, classically had in aortic stenosis of bicuspid valves. So you can appreciate the click in aortic stenosis of bicuspid aortic stenosis, and intensity correlated with the pliability of the valves. The valve interest should be pliable in order to generate clicks. Earlier the ejectional click to first sound, severity is the aortic stenosis. Systolic clicks and non-ejection click. Ejectional click appreciated in pulmonic and aortic stenosis. Okay. Non-ejection click are associated with mitral regurgitation. What are the features of non-ejection click? They are short, high-frequency clicky sounds, confined to apex or transmitted widely on the precordium, occurs in middle or late systole, shows respiratory or positional variation or even timing from beat to varying, even in they vary in the timing from beat to beat. Okay, usually single, but multiple clicks may also be there. So they are not localized strictly. They can be heard all over the precordium. Okay. Coming to the diastolic sounds. What are the diastolic sounds? Diastole follows the second heart sound. Okay. Second heart sound, third heart sound, fourth heart sound. Diastolic knocks, mitral valve sounds. Okay. These are softer, low pitched, and longer in duration. Okay. S3 is normal in children. S4 is pathological in children. Let us discuss one by one. Second heart sound. It precedes the diastole. That means the diastole begins with the start of the second heart sound. It is produced by the closure of aortic and pulmonic valve. Aortic valve closure closes early, followed by pulmonic valve. Okay, you can appreciate the split. Split is wide in left bundle branch block. Okay. And also in aortic stenosis. In left bundle branch block, what happens? There is delay in the closure of the aortic valve. In the same way, in aortic stenosis also, the aortic valve closure is delayed. So there will be narrowing of the split. Because aortic valve component falls on the pulmonic valvular component of the second heart sound, and the split is narrowed. Wide splitting is appreciated in the right branch block and atrial septal defect. This is because of the increased right ventricular output. Okay. And this abarshes the variable closure of the pulmonic and the aortic valve closures with respiration. So that is the wide fixed splitting of the second heart sound is classical feature of atrial septal defect. Because here the atrial filling. So the right ventricular filling, and so the right ventricular output does not change with regard to the respiration. So the duration of the right ventricular systole is constant in both the phases of respiration in atrial septal defect. Okay. In inspiration, there is increased venous return, and so filling of the right ventricle. In expiration, there is increased venous return from the pulmonary circulation to the left atrium. So the left atrium to the right atrial shunt will be increased. So increased right ventricular filling in both the phases of respiration. That does not show any variation with regard to the right ventricular filling with regard to the respiration. So the closure of the pulmonary valves is same, does not make any change during both the phases of respiration. So timing when does not change, so the split is constant. It is fixed and wide splitting of second heart sound, characteristic feature of atrial septal defect. And also right bundle branch block. Single and loud sound, loud second sound is a feature of pulmonary hypertension, because there is early closure of the pulmonary valve and pulmonary component of the second heart sound falls under the aortic component. Then there will be single and loud second heart sound. This is the characteristic feature of Eisenmenger syndrome, where there is a pulmonary hypertension in right to left shunts. Wide but variable splitting occurs in large left to right shunts. Reverse splitting is characteristic feature of severe aortic stenosis. So aortic component is much delayed beyond the closure of the pulmonary valves, thereby resulting in reverse splitting of the second heart sound, wherein pulmonary component is heard earlier than the aortic component. Coming to the third heart sound, it is soft, low pitched, immediately follows the second heart sound. Okay, this occurs due to the rapid filling of the ventricles during early diastole. It is a sign of hyperdynamic circulatory state. It is best heard during inspiration with patient lying supine. You have to appreciate with the bell of the stethoscope just internal to the apex. It is physiological in children and during pregnancy. Fourth heart sound. It is also soft, low-pitched sound, best heard with the bell of the stethoscope. It is appreciated in the late diastole. It is due to the rapid filling during the active left atrial contraction. Okay, it occurs in the late diastole. It is pathological in children, common in adults. It is because of the poor compliance of the ventricles to receive the blood from the left atrium into the left ventricle during the active atrial contraction. Summation gallop. It is nothing but the merging of the third and fourth heart sounds occur during a tachycardia due to shortening of the diastolic period. It is palpable at the apex in left lateral position. Because merging of two sounds, it will give a thudding sound which can be palpable in left lateral position at the apex. This is called summation gallop. Diastolic knock. Loud thudding sound heard in early diastole. The timing is same as yesterday. This occurs due to early rapid filling into the left ventricle, which is poorly compliant. So restricted left ventricular wall relaxation due to constrictive pericarditis results in diastolic knock. Coming to the opening snap, it is short, high-pitched sound heard in early diastole. It occurs soon after pulmonary component of the second heart sound. Okay. Best heard with the diaphragm of the stethoscope just internal to the apex. It is heard in matter stenosis when the leaflets are still pliable and elastic. The closer the opening snap to second heart sound, severe is the matter stenosis. It becomes soft and absent if the wall leaflets are sclerosed and disappears with the onset of atrial fibrillation, because in atrial fibrillation there is no active contraction of the atrial chamber. It disappears in atrial fibrillation. So no opening snap is heard in atrial fibrillation. Well, thank you very much, my dear students, for patient listening. Remember these points with regard to the cardiac cycle and appreciate the sounds with full concentration and attention while you are auscultating the child with cardiac elements. Thank you very much once again. We'll meet you next time in the next class, in which we are going to deal with the auscultation of murmurs. Until that time, bye-bye.